Thank you, Matt, for this kind of introduction. Before I begin, I want to thank the scientific committee for inviting me. It is an honor, a pleasure to talk about this important, interesting topic, which is molecular heterogeneity in HER2-positive disease. Can clinical outcomes be predicted? And these are my disclosures. I would just like to mention briefly that I will briefly talk about HER2-DX, which we have filed a patent and license this patent to reveal genomics. So I think it is clear in 2021 that the current definition of HER2 using the ASCO-CAP guidelines is not enough. And even if we subdivide this disease according to estrogen receptor status, is not enough. Thanks to many studies done over the last decade, we have learned a lot about the biological heterogeneity that exists. And I think we're starting to link these two clinical outcomes. I think it's important to highlight that we need to look at HER2 first as a target. Second, we need to think about HER2 also as a transmembrane receptor that has activity and can activate downstream signaling pathways. Also, the tumor microenvironment is important, as well as other features. But no doubt that this is a disease that a lot of research has been done. Some of these biological heterogeneity is linked to clinical outcomes. The question is how we can use this biological information to make better treatment decisions. So let me review some of the data in the next 15 minutes. On one hand, it is clear that although we have a definition of HER2-positive disease, this is a biomarker, a target that whose expression runs as a continuous variable. Even by immunohistochemistry, this can be seen from HER2-0, HER2-1+, 2+, and 3+, by other more sophisticated assays, more sensitive assays such as proteomics based assays or mRNA-based assays. This is even more clear. For example, we know today that even within HER2-positive disease and 3+ category, there is still a group of patients that have very high levels of the target, and they seem to respond more to anti-HER2 therapies. And there is 1/3 of patients that we're calling them in the clinic as HER2-positive, even 3+, but still they have lower levels and they respond less to anti-HER2-based therapies. In fact, if we look at this group, the so-called HER2-positive, and we include the 2+ with amplification and the 3+, clearly we see that by more sophisticated assays such as mRNA, one can see a huge range of expression, more than 12-fold difference across the samples, even within the 3+ category. So there is a lot of heterogeneity, even within the 3+ group of patients. We've learned, for example, that by just looking at the RBB2 mRNA at baseline in pretreated samples, this biomarker, even within HER2-positive disease, this is associated with more response to anti-HER2-based therapy, and this has been shown very clearly in the neoadjuvant setting. Here you have at least 6 different studies looking at anti-HER2-based therapy with chemo or without, showing that always those tumors that are HER2-positive but have very high levels of the target, by looking at RBB2 mRNA, they respond more in terms of pathological complete response compared to those that have lower expression. So clearly more RBB2, more response even within HER2-positive disease. Even in the metastatic setting, this has been also shown with drugs such as T-DM1. Here you have the Emilia phase 3 clinical trial on the left, the Teresa trial on the right, and these were retrospective analyses with more than 80 samples of these pivotal trials profiled, showing that RBB2 mRNA can identify a group of patients that do better with T-DM1, and even regarding the interaction test, even its predictive value using interaction test almost reached the statistical significance in the Emilia and was statistically significant in the Teresa. So showing that not only it enriches for those that will do better with T-DM1, but also might be predictive of a treatment benefit to this drug. So I think very consistent data across many different studies. More recently, we've seen, looking now at residual tumors after neoadjuvant anti-HER2-based therapy. In these residual tumors, RBB2 mRNA was evaluated in the Catherine phase 3 clinical trial, where patients were randomized to T-DM1 versus adjuvant trastuzumab, showing that it's especially in the RBB2 high group that the differences, the magnitude of the difference or the magnitude of benefit to T-DM1, I would say, is huge, with a hazard ratio of 0.30 in those tumors that have RBP2 low, here defined as below the median, and the benefit from a relative perspective and from an absolute perspective is lower. Again, very consistent data, even in early disease, as well as in metastatic breast cancer. Of course, this biomarker is not ready for prime time, but it does suggest that by looking at this heterogeneity within HER2-positive disease, we see different responses and clinical outcomes. When we talk about within HER2-positive disease, those tumors that have lower expression of RBP2 or HER2 protein, and they respond less to these therapies, the question is why? Why? Is it because they just have less target? Is it because, for example, there is intertumor heterogeneity, and as has been reviewed by Sarah Tolani in her talk? It could be a mix of things, but no doubt this group needs attention because they don't respond as well to these therapies, at least with standard anti-HER2-based therapies. The question is, why do RBP2 high tumors respond to anti-HER2 therapy? Why within HER2-positive disease, those that have very high levels of RBP2 respond more? So this is something that we reported last year, a little bit more, showing that within the RBP2 high is where you identify more HER2-enriched disease by intrinsic subtyping, the pink subtype, 83% were HER2-enriched, whereas in the RBP2 low, there is more heterogeneity in terms of intrinsic subtyping. Still, there are substantial amount of HER2-enriched, but here you see many more luminals and a few more basals. So definitely the RBP2 low is more heterogeneous, and this could explain why these tumors respond less to anti-HER2 therapy, and they are less, I would conclude, they are less HER2 addicted. This is kind of what we see when we look at hormone receptor status within HER2-positive disease. Hormone receptor status also can enrich for one subtype versus the other. For example, in hormone receptor negative HER2-positive disease on the right, the vast majority, 3 out of 4 tumors are HER2-enriched. They are HER2-driven. That's probably why hormone receptor negative tumors respond more to anti-HER2-based therapy in the neoadjuvant setting. And in hormone receptor-positive disease, you still see 30% of HER2-enriched, but the vast majority of luminals are identified here. So the hormone receptor status, it's explaining part of the underlying biology that is going on in these tumors. But definitely, hormone receptor status is not enough. There is much more heterogeneity than just hormone receptor status. Interestingly, not only HER2-positive disease is important, and heterogeneity there is linked to clinical outcomes, but as you know, now we have a new, let's say, category, the HER2 lows, which are becoming more and more important as an potent ADCs are showing activity in this group of patients. Here I'm just pointing out to 2 different publications, one from our group, showing that this group is still highly heterogeneous, the HER2 lows. I would not conclude it is a biologically different entity. It is just a group of tumors that have intermediate expression of HER2, but underlying that, what you see is that most tumors are not HER2 addicted. That doesn't mean it's not important to target, but the signaling pathway downstream is not there. This is basically what I just said. If you look at HER2 1+ or HER2 plus 2 is negative, you see that the vast majority of these tumors are blue, meaning luminal A, luminal B, just 3 to 4% are HER2-enriched, and there is still a substantial amount of triple-negative basal-like tumors there that do not seem to have high activation of this pathway. So again, HER2-low tumors are not HER2 addicted, and therefore strategies to deliver chemo in this group of patients make sense, but the strategies to inhibit the pathway might not work much in this group of patients. At the same time, I mentioned at the beginning, there is heterogeneity at the microenvironment level in terms of TILs or immune genes. Definitely, there are HER2-positive tumors that are immune inflamed, some that are not. We know that immune inflammation is associated with better outcomes and also better response to anti-HER2-based therapy, especially with chemotherapy. And this has now been shown across different studies. These are just 3 examples showing this very nicely and showing that this is independent of tumor features. So they provide independent predictive information. So I think today in the neoadjuvant setting, we have many studies showing that there is a substantial amount of biological heterogeneity, looking at tumor cell features, HER2 enriched especially versus not, looking at the target, RBB2 high versus not, ESR low, or hormone receptor status negative is associated with more response, and immune-related signatures, T cell and B cell signatures, have all been linked to more response, more probability of achieving a pathological complete response. But at the same time, what these studies show is that all these variables together provide independent information. So each one of them is unique. And if you want to really predict PCR or outcome, you need to start linking all these features together. This is a very interesting study by Arantxa Fernandez from Chuck's Peru laboratory at UNC, showing a retrospective analysis of the CLGB 406-1 HER2-positive phase 3 trial. And they did an amazing effort in pretreatment baseline samples to purify RNA and perform RNA-seq analysis in 600 and evaluate 688 different biomarkers. And what they showed is that 1/3 is associated with PCR versus residual disease. 7% are associated with relapse-free survival, so the percentage is much lower for predicting relapse-free survival, and only 3% were associated with both, predicting PCR and predicting relapse-free survival. In particular, you can see that there are some variables, such as HER2 enriched, that are associated with more PCR, but also worse relapse-free survival. The immune signatures are the only ones that show higher likelihood of PCR and better outcome. And signatures such as luminal A, the opposite, lower PCR, but better outcome. So the conclusion is that it is easier to predict PCR than relapse-free survival, and predictors of PCR do not always predict better relapse-free survival, and vice versa. So we need to start distinguishing the two clinical endpoints and the biomarkers associated with them. We did an exercise also last year trying to combine different tumor cell features, microenvironment, as well as tumor burden, tumor size, nodal status, into a single score, the so-called HER2-DX risk score. And we validated this in an independent data set. We also showed in that publication that the HER2-DX risk score was not associated with PCR versus residual disease. So an assay developed to predict relapse-free survival did not predict pathological complete response, again suggesting that the two are different. Here's a summary of the new HER2-DX prognostic score, but also we have developed a HER2-DX predictive score. This has been submitted for publication, but I'm just going to show this slide just to show you that the different components of the HER2-DX, the immune component is associated with better outcomes, but also better PCR. The luminal component is associated with better outcome, but worse PCR or worse probability of PCR. Proliferation is associated with worse outcome, but a better probability of achieving a PCR. And tumor burden, as expected, is associated with worse outcome and worse probability of achieving a pathological complete response. So I think starting to distinguish each variable and how they relate to each clinical endpoint is important as we develop multivariable and multivariate or multi-analyte models. And finally, one last part, I think, is that not all heterogeneity is captured at baseline before starting therapy. There is some information that can only be captured during therapy and might be important. So on treatment, tumor biopsies might bring additional heterogeneity, but at the same time, additional important clinical information. This is one study, an example of the type of information that on-treatment samples can give. This is work led by Matt Ellis and colleagues, showing in patients treated with anti-HER2-based treatment that on-treatment samples, and specifically if you look at phosphoproteins, and in particular HER2 phosphoprotein, it can identify patients that are most likely going to achieve a pathological complete response once they complete neoadjuvant therapy. And in particular, what they showed here is that the decrease of phospho-HER2 is associated with more PCR than those tumors that do not show any change in phosphoprotein levels at the level of HER2. So very interesting data of how on-treatment variables can help. In addition, this year in Nature Cancer, it was reported this very nice study looking at spatial proteomic analysis after short-term anti-HER2 treatment, showing very nicely. First is that on the first top row, you see estrogen receptor negative cases and estrogen receptor positive cases. On the bottom, you see the HER2 enriched on the left and the non-HER2 enriched on the right. And you can see that most biological changes, so proteins whose expression goes down and proteins that go up, mostly happen in hormone receptor negative and in HER2 enriched tumors. Again, these are the tumors more sensitive to anti-HER2 based therapies. In particular, what you see is that genes such as HER2 is decreased in general on treatment, whereas immune genes are upregulated on treatment. And this seems to be a general effect going on in estrogen receptor negative tumors as well as HER2 enriched tumors. So very consistent data, as you can see, across different studies. In fact, we have shown that this increase in immune infiltration on treatment after just 2 weeks of anti-HER2 based therapy, increasing TILs and decreasing tumor cellularity is predictive of long-term clinical outcomes. In this case, this is analysis of NeoAlto. There was a biopsy before and at 6 weeks of just anti-HER2 based therapy without chemo, just trastuzumab or lapatinib or trastuzumab lapatinib, showing that those tumors that are becoming inflamed at 6 weeks and tumor cellularity starts going down, these are the patients that will do better in terms of long-term EFS and long-term overall survival. So to me, this is really striking to see how early on treatment biomarkers can tell us so much about what would happen in the long term at 5-6 years. So the take-home messages of my presentation are as follows. I think within HER2 positive disease, we know there is heterogeneity, we can capture it, high RBB2, HER2 enriched, PIK3CA wild type that I did not discuss, hormone receptor negative and high TILs immune, all are associated with tumors that are more anti-HER2 based therapy sensitive, and they're more HER2 addicted. That biomarkers of PCR do not always predict survival outcomes, so they need to be related to their particular clinical endpoint that are being associated. That biomarkers of survival outcomes are difficult to identify. CLGP 406 is clear, and combination of variables is probably what we need next to start combining different variables to predict either pathological complete response or to predict long-term survival. And finally, on treatment biomarkers, especially in HER2 positive disease, I think provide additional information regarding the patient's outcome at surgery and also long-term outcome, and they should be incorporated in all future clinical trials. And with that, I'm going to thank you, and I'm very happy to have a discussion. Thank you very much.